Speaker Dr. Suresh Kumar to deliver his topic on complications of glaucoma drainage devices.
Very good afternoon. At the outset, I am grateful to AIOS for the invitation and opportunity. Respected chairperson and dear friends, I will be speaking on complications of glaucoma implants. As you are all aware that glaucoma implants have become mainstay of surgical treatment of refractory and complicated glaucomas. However, these devices have their own issues and they can have their own set of complications. These complications can be valve related, structure related or surgery related. As Dr. Kirti Singh pointed out that trabeculectomy can have hypotony. Similarly, implants can have hypotony as well as hypertensive phase. Hypotony is IOP persistently below 6.5 millimeter mercury. It can be immediately postoperative, it can be transient or persistent, or it could be late onset, which is more likely to be persistent. And we are always worried about persistent hypotony after implant. It's even more serious than after trabeculectomy. And incidence of hypotony varies with type of implant, and we are more likely to see hypotony after non-valvular implants, that is Berweld or Adi implant. And causes of hypotony can be leakage from the surgical site, inadequate capsular formation to aqueous outflow. Then this could be non-device related like choroidal detachment, cyclitis or perforation during the surgical steps, or it could be transient aqueous hyposecretion. And hypotony with associated choroidal effusion, mostly if it's small effusion, it will resolve automatically. After some time, large effusion, especially kissing choroids, may need choroidal drainage. And as the treatment of hypotony is difficult, it's better to prevent the hypotony. So either use a valvular implant or occlude the silicone tube by a stent or a ligature suture to prevent hypotony. And with hypotony, we are always worried about hypotonic maculopathy. You can have on fundus examination, you can see chorioretinal folds, retinal detachment, optic nerve head edema, cystoid macular edema, or there could be loss of central vision. So diagnosis is pretty obvious on your fundus 90-day evaluation, but sometimes OCT can help us in picking up the maculopathy and retinal edema. And management is mostly surgical, as Dr. Kirti pointed out. Remove the bleb and apply a scleral patch graft, cover with amniotic membrane and conjunctiva, and hypotony will be taken care of and maculopathy will resolve after some time. And management of hypotony, it's more serious as compared to trabeculectomy. And if hypotony is there with normal chamber, your endothelium is not threatened by the tube, then you can observe. And if there is wound leakage, you repair the wound leakage. If it's choroidal effusion, then steroids and cycloplegics, and sometimes you need drainage. And if there is hypotony with flat chamber, you have to reform the chamber. And persistent hypotony, sometimes you have to apply ligature or you have to remove the implant also. However, the hypotony can have sinister underlying cause, like our patient had surgically induced scleral necrosis after rheumatoid arthritis. He had in fact rheumatoid arthritis, so after implantation of AGV, he had surgically induced scleral necrosis. This has been published in Journal of Glaucoma. So after 2 or 3 weeks, patient started showing area of scleral necrosis where implant had been put, and there was hypotony also. So unfortunately, even with immunosuppressive, azathioprine was given systemically, and 2 times scleral patch graft was put, but patient, we are not able to salvage the vision in this patient. So we have to be really careful. If patient is having underlying collagen vascular disease, we should be avoiding implants in these patients. And one of our patients, elderly female patient with pseudophakia, she had malignant glaucoma following implant, and the confusion was the pressure was on lower side. So malignant glaucoma can have IOP in the range of normal or even low levels. The chamber was flat and UBM confirmed diagnosis in this patient, and patient did well after surgical vitrectomy and reformation of anterior chamber. This has been published in Indian Journal of Ophthalmology. And another aspect is hypertensive phase, which is seen due to bleb encapsulation. And patient hypertensive phase we are worried about because it can lead to further loss of vision because patients are already having quite advanced glaucoma. And before we label a patient as hypertensive, we have to rule out outflow obstruction, which could be because of blood, fibrin, vitreous, lens material, or kinking. And laser works nicely if the tube is blocked by vitreous strands. Like this patient, you can clearly see the tube has been blocked by vitreous strands. And after ND-JAG lysis, the tube started working again and IOP was controlled. And if we don't see anything obstructing the outflow, then it's hypertensive phase. It can occur as early as 3 to 6 weeks following surgery, or it can occur even late, 4 to 6 months after surgery. You can have typically congested eye with tense inflamed bleb, and IOP is normally more than 30-35 millimeter mercury. And preoperative risk factors can be very high preoperative intraocular pressure and high myopia. And your type of device, like it's more commonly seen with Ahmed glaucoma valve or valvular devices. Few of our patients with inflamed eye or tense bleb. And management is you increase the frequency of topical steroid. If it's a non-valvular implant, do the suture lysis, remove the ligature, do bleb needling to break fibrotic bands. If it's not improving, with conservative treatment, and sometimes if it is fibrotic capsule, you have to remove the capsule and put amniotic membrane, cover it with conjunctiva, then it starts working again. And structural complications, outflow obstruction has been discussed. Conjunctival erosion, implant explosion, tube migration can be seen in one patient also. Diplopia, if it's a large bleb, it can lead to mechanical obstruction and can cause diplopia. The erosion is seen in overall 2% of the patient, and all these factors, they make erosion more prone, more likely in these patients. And if it is small, limited, direct closure, if it is large, sometimes you have to put a patch graft, and recurrent erosion may require explantation of the implant. One of our patient is a child, she underwent AGV and she had trauma, never informed the parents, and came with this picture. Tube has been extruded and there was a patch of corneoscleral necrosis with iris prolapse. And then 3 millimeter corneoscleral patch graft was done, tube was cut, and child did well after the surgery. There could be surgery related complications like hyphema, cataract, corneal decompensation, endophthalmitis, vision loss, and surgical failure of your implant. And one of our patient had postoperative endophthalmitis. Unfortunately, we were not able to salvage the eye. So hypotony with normal chamber, observe. Hypotony with shallow chamber, treat the cause. Hypertensive phase, again conservative management in majority of patients. Sometimes you have to do bleb revision, and early recognition and prompt treatment is key for management of these patients. Thank you.
Thank you, Dr. Suresh, for that wonderful exposition of complications of glaucoma drainage devices because of paucity of